So today we will be dealing with the post-traumatic stress disorder specifically, and in general about post-traumatic conditions. When we talk about post-trauma, we are referring to some external event that causes psychological trauma. So this is to differentiate it from physical trauma, which is injury to the body. There is some wounding, and here the event is of such a nature that it causes trauma to the mind. And this is can be the result of experiencing or witnessing an event of such magnitude that it is life-threatening. It includes danger or some injury to the person, and usually leaves the person horrified and feeling helpless, terrified. These are emotions that are usually experienced in a traumatic event. So when we look at it more specifically as diagnostic criteria, first there has to be this kind of event, external environmental event that happens, or it can be a series of events that is exceptionally threatening. So this term exceptionally is very important here, that is beyond normal everyday experiences, exceptionally threatening or catastrophic experience. Usually we are talking about of a magnitude that we call disasters. So disasters can be natural disasters, like in Sri Lanka there are tsunami, or like big volcano or big floods that happen suddenly, and man-made disasters like war, big incidents or industrial accidents, or some things that are done purposefully like torture or rape, and usually leaves the person experiencing terror and helplessness. The second important criteria that has to be met if we want to diagnose PTSD is that event that happened, that exceptionally threatening catastrophic event, is re-experienced. So that is later, maybe weeks or months later, the person re-experiences the event as if it is happening again. And this can be re-experienced in several ways, and we mentioned some common ways that it can be experienced. One is like intrusive recollections or memories as images, or it can be even in dreams, or as it may come as nightmares. And the person feels that it is happening again. They relive, so that it is as if it's happening in the present, that they are there. Sometimes they are called flashbacks. So from the present they go back to the event, and it's as if it's being replayed, like in a video. They experience the whole thing happening. Reminders associated with the event, something that triggers the memories. For example, if it involved armed uniformed men, seeing people in uniform can trigger the re-experiencing. So those are the two fundamental, one the catastrophic event and the re-experiencing the event. In addition, we need to look for avoidance. So people try to avoid situations, reminders that can bring back the memories that they associate with what happened, and they may avoid situations or places that may remind them, and they may take action. They may avoid looking at TV where there may be programs showing, say, for example, war events. So active avoidance and they also experience a kind of a numbing of their emotions, their responses. It's a kind of a benumbed, like an anesthetized person. And finally, there are signs and symptoms of hyperarousal, particularly sympathetic hyperarousal. One of the characteristic features is insomnia, difficulties falling asleep, where there may be nightmares. Hypervigilance, the person is always tense and alert, and even a small noise can cause a startled response. They almost jump. Lack of concentration, irritability, sometimes anger, hostility can be seen. There may be violent or aggressive outbursts. PTSD is often associated with other psychological problems. Very common is anxiety and depression, which usually seem to happen together. So, they are called comorbid conditions. In some cultures, we find that it is very often manifested as somatization, physical complaints without organic basis. Alcohol and drug abuse is often resorted to due to the distress, to benumb, to make the person escape from the distressing memories, alcohol and drug abuse. Now, when we look at some of the pathological basis changes in the brain that are found in people who are suffering from PTSD, one of the major sites that seems to be involved is the hippocampus. And if you look at the hippocampus in normal people, it may be a little elliptical round area. In people with PTSD, there seems to be a shrinking and almost like a flattening of the whole amygdala, the hippocampal area. Similarly, the other areas of the brain also have been shown to be affected, particularly through MRI studies, for functional MRI that shows maybe differential blood flow or activity of these areas. So, the areas that have been identified is particularly the prefrontal cortex, the anterior cingulate cortex, which may be associated with the limbic lobe to some extent. The amygdala seems to be hyperactive, particularly in relation to fear responses. And as we already mentioned, the hippocampus also, there may be a shrinking of the hippocampus. So, if you look at the whole pathophysiology, trying to understand what is going on in PTSD, they have identified, they have developed a model trying to understand what happens, and they have identified a kind of fear conditioning. The person becomes conditioned to certain triggers, to certain events that resemble what happened, so that certain areas seem to react sometimes excessively to even neutral environmental events that normally would not elicit a response, but in people with PTSD there seems to be an excessive response. So, that there is a kind of a sensitization, a kind of super sensitivity to certain events and certain triggers. And usually when you look at the functioning of the brain, different areas of the brain, particularly like the amygdala and so on, and the hippocampus that may have the memory of what happened, after some time the body sort of settles down, calms down. There is an what they call extinction of a, say they see a fearful stimuli, after the initial response the body will settle down. But in PTSD, there is an inhibition of this extinction, so that the response goes on and on and on. Person does not get any relief. So, this is a kind of working model to show which are the areas that are involved, and particularly they identify the amygdala, hippocampus, thalamus and so on as being involved, and the locus coeruleus and areas in the midbrain and brain stem may be involved in the response, the hyper alert state that you get in PTSD. Now, when we look at the epidemiology, particularly in our area of the world in Jaffna, where we have done some studies, we find that PTSD in the general population, because most people have experienced war events, they have been caught up in situations of direct fighting, they have seen people being killed and so on. In our survey, we found about 28% met the diagnostic criteria for PTSD. When you look at use a stricter criteria that's found in the DSM-3R, it dropped to about 14% PTSD. When we compare it with the OPD, we find that people who come there have a higher incidence of PTSD. So, it may be that people with PTSD are seeking relief, help-seeking behavior by coming to OPD with somatic complaints. They don't come and complain of their psychological problems, they mainly complain of somatic. The incidence goes up dramatically under certain populations that have faced extreme, for example, torture, goes to about 85%. Another study found that students in the VANI, that is people attending school, which student population, they had a incidence of 25%. After the tsunami, we did a study in the schools that were directly affected, in the affected areas. About 50% of the students showed signs and symptoms of PTSD. So, we will show this later on. So, we have done some studies that have been published in leading journals, British Journal of Psychiatry and the International Medical Journal, and we looked at the various types of war stresses that the community has faced. It was done in the community medicine study area in Coquille and in the Jaffna Hospital OPD. And you can see the different types of events that people have faced. These are all traumatizing events of a very severe nature. Torture, indirect stresses like displacement. Is quite a large number of population have undergone this kind of experience. So, then we look at the consequences of this kind of experiences in the same population. So, it is a same study. We look at something like PTSD, we already mentioned. In the community, maybe it is around 27%, and it goes up to quite a high level in the OPD. Similarly, with somatization, depression. So, all these conditions are found widely prevalent in the community. When you compare it to the OPD, it is much higher. So, one explanation is that people are seeking help for their psychological problems by going to the OPD. This is the VANI study, which looked at various trauma events in the school population. This is another study after the tsunami, comparing populations in the north with the south after the, and they found that in the north incidence was higher, particularly conditions like PTSD. So, this is also after the tsunami. We find that students who were within 300 meters of the tsunami, so right on the sea, there was a high incidence of PTSD, while students who were far away, more than 300 meters from the sea, there was less, although both populations have in a war situation. So, there may be a background incidence of PTSD, but it is much higher in people in students who were directly in the path of the tsunami. Similarly, in a clinic that we ran in one of the badly affected areas in Maradangani, after the tsunami, we found the incidence of PTSD and other conditions like depression and so on was very high. 53% of people had PTSD. Another very important study that was done in Jaffna subsequent to the 2006 to 9 war in the Vanni. After the war was over, this was done by quite a few researchers, including Farah Hussain, who was from the UNICEF, Aishara Vidana from the Ministry of Health, and it was published in the Journal of American Medical Association, a very prestigious leading journal, which showed in the survey that people in Jaffna, so this Jaffna carried out in Jaffna, they have experienced quite a number of serious traumatic events that happen in war, like bombardment, crossfire, and death of a family member, they themselves being assaulted or tortured, kidnapping, and so on. So you can understand how a population that has undergone such amount of trauma may be affected psychologically. And they found that when they looked at for particular disorders, PTSD, 7% of the population had PTSD. While if they looked at anxiety, higher percentage, 32%, depression 22%. Then they compared the general population in Jaffna with the internally displaced people who had been in the Vanni and who had returned. The other population was in Jaffna and they had not exposed to the war directly, the Vanni war. They had been exposed to war before that. And there they found that more than half had experienced more than 10 traumatic events, while 41% had 5 to 9 events. And there the PTSD was almost double, 13%. Anxiety was 49% and depression 42%. So all higher than the Jaffna population. So what we have been saying is that the war events and also disasters, natural disasters, cause post-traumatic disorder, depression, and anxiety. These are the three common manifestations that are well known. It can also manifest as somatoform disorder with somatic complaints without organic basis. As we mentioned already, alcohol and drug abuse. People who have been exposed to trauma over a long term, severe trauma, particularly children who are not able to escape from the situation, interpersonal violence, child abuse, sexual abuse, they develop long-term changes in their personality. And it is sometimes now called complex PTSD because of the complex nature of the manifestation and long-lasting changes in personality functioning. And of course, they can manifest with other relationship difficulties and sexual problems. Now, not only the trauma affects the individual, it also affects the family, the functioning of the family dynamics. So we look at it, we look at some of the changes when one member is killed or disappeared or there are separations, it can affect the family unity, the cohesiveness, and the death causes a vacuum. So if the father or mother is killed, there's a vacuum and the others have to manage. So there may be a single-headed household. Families may get separated, particularly during the acute phase of disasters, both during the war and after the tsunami. And as we mentioned, changes in the roles. For example, after the tsunami, there were increased deaths of females, and the husbands found it very difficult to manage the family. In the war, there were more deaths of males, and the females had to take the role of the husband also and lead the and attend to the functions usually done by the male. Now not only at the level of the family, but there are effects at the community level. Whole villages sometimes are displaced, or important institutions and structures are destroyed. People, elders, leaders may be killed. So that there is a kind of a destruction of that the functioning community structures and traditions and networks. So that feeling of belonging to some, in Tamil, the Ur, or being in a community is lost, sometimes called loss of communality, first used by Kai Erikson in relation to a disaster that happened in the States. The connections with the home, the house, the wood, people are displaced, they have to leave in a hurry, and the close bonding with the house may be lost. So we have called this kind of effect at the family and community level collective trauma, and this causes changes in the social fabric, in the way that societies function, the relationships and so on. And particularly some communities like the indigenous communities and minorities who are persecuted may develop what we call historical trauma that goes on from generation to generation and may be passed on, what we call transgenerational effect. So the collective trauma can affect whole communities, and the effect can be seen in some other parameters in society, like distrust, loss of motivation, loss of beliefs and values and norms, kind of helplessness, antisocial behavior, domestic violence, child abuse and suicidality. So these are reflection of the lack of social support, the lack of social cohesion, the breakdown in social norms and values. We must just mention that this is not a view of the WHO, where collective trauma is mentioned in the new ICD-11 diagnostic system, but this is the description found there. If you want to read more about the new diagnostic criteria, there are publications both in the Lancet and the World Psychiatry about the new diagnostic criteria being used in situations of post-trauma. So in summary, the symptoms of collective trauma: loss of communality, the loss of relationships, mistrust between people, suspicion, people become silent, they don't participate, they don't talk out, there's a deterioration in values and morals, and the leaderships may be killed, or they may be displaced. So there's a lack of leadership also in the community, and people become dependent on outside help, on rations, on handouts, and they may lose their independent nature. So they are always expecting some kind of aid, outside aid, and the goals are very superficial. So there is a kind of generalized social deterioration in situations of after disaster, and it's in a way we are able to understand this, and we are able to maybe design proper implementations and interventions that can address some of these aspects. There may be increased violence, crime, domestic violence may be seen, child abuse, alcoholism, and increased suicidality. So, when we try to design interventions in a post-trauma situation after a big disaster, we can plan and try to direct the interventions. It is useful to look at it at different levels. So, we can have interventions that would target the society at large. So, we work on policies, public policies, or try to increase the safety of the community. We can do a lot health education at the community level. We can target quite a large population through the media, through workshops, through productions like a drama and so on, where health information can be passed on through pamphlets and so on. At the village level, we can rebuild capacity, leadership, sharing, social skills and so on. Work with families through education to empower the families, rebuild unity, cohesiveness and so on. And at the individual level, which is very time consuming, very involving professionals, more expensive, we can treat clinical individuals who have PTSD. So, we have developed this kind of model where we can address severe problems at the psychiatric through psychiatric care at a district level, through psychiatric clinics with psychiatrists and multidisciplinary team, through the primary health care, through the primary health doctor, family health workers and so on, and at the community by training community level workers. So, they can address quite a number of problems, they can build the society, societal structures that have been affected, rebuild them, networks, the support system and so on. And they can refer to each other. So, we get a referral pathways. If there is a problem in the community that is very severe and they find it difficult to manage, they can refer to the primary health level, or it can go up to the psychiatric level at the district level. So, we have a referral pathways and the person can be seen there, treatment initiated and then referred back to the community for follow-up. So, what are the treatments available in a PTSD or post-traumatic situation? There are quite a few interventions that have been developed. Some have quite a strong evidence base, some have been found not to be helpful. For example, debriefing has been now shown not to be helpful, sometimes harmful. But first aid, psychological first aid, where people can be supportive and can be helpful in finding, say, a place to stay or to reunite the family, can be very useful method for people who have been affected by disaster. Then counseling, supportive listening and supportive interaction. Cognitive behavior therapy, particularly exposure and desensitization, has been shown to be very effective. Relaxation exercises through like for example yoga, people who have been tortured has been found to be very effective. Various forms of expressive therapy and so on. Family therapy, we will come to some of these later on. Particularly drugs have been used quite a bit. So, for PTSD, drugs of choice are the SSRIs, even the older tricyclics like amitriptyline and imipramine are also useful, particularly for the intrusive memories, re-experiencing, and also it may help with the sleep to calm the person down in a hyper-aroused state. Neuroleptics have been found not used that often, but sometimes in complex PTSD, they may use neuroleptics like particularly quetiapine. Carbamazepine has been tried in people who have shown increased irritability and hostility, aggressive and violent outbursts. It may be used. Rehabilitation to bring them back to fairly reasonable level of functioning back into the family and society, particularly those who have been involved in the fighting. So, in the demobilization phase, rehabilitation is very important. preventing war, I think, would be a very important way to reduce the incidents, but also in conditions like natural disasters, can take precautions in the buildings, so, strong buildings, zoning, having certain areas that are not built upon, say right by the sea. So these also can be used, and certain practices like torture should be banned completely. Rape, these should not be seen at all. So what we do, we have psychological education, psychoeducation is called, so giving information, empowering people and communities to look after themselves, giving the skills, basic simple skills, relaxation, what to do, not to do, various forms of psychotherapy including counseling, CBT techniques like exposure therapy, habituate them to what happened in a calm, supportive environment, relaxation techniques, pharmacotherapy, we already mentioned the SSRIs and tricyclics, group, bring together group of people who have been affected, women-headed households, bring the women together, tortured people who have survived torture, they come together as a group and share and help each other, very effective. Family, reunite the family, improve the relationships, expressive methods like art and drama help to bring out the emotion, help people to express. Rehabilitation, as we mentioned, is a very important method of bringing the person back into his family or social functioning. So individual psychotherapy can be of various modalities, and I have mentioned just a few. Cognitive behavior therapy is now considered the treatment of choice, and one that's promoted is exposure therapy, and that can be done in small doses. They are exposed to the traumatic event, where they are able to habituate to what happened and come to terms with it. Family therapy, as we mentioned, reuniting the family, increasing the understanding and support within the families. Groups, bring together groups that have been affected similarly, like widows or alcoholics, people who have survived landmine injuries, who may have lost their legs or limbs, so on. Then certain cultural rituals, as we have mentioned earlier, have been very helpful after a big disaster, and this has been found all over the world, and certain purifying rituals can help a community recover. So these are to be promoted and encouraged, trying to restore cultural practices that community is familiar with. And the group of experts have recommended the following after a massive trauma experience: to create a sense of safety so that it won't happen again, or that it won't affect them, that they are feeling safe, then calming them, which can be done through various relaxation methods like yoga, mindfulness, and so on. Sense of community efficacy, the community is still powerful, the community can still act in a positive way. A sense of connectedness, relationships, networks, and a sense of hope. So these are kind of general community based approaches trying to rebuild the society after a traumatic event. The techniques that we have used here, we have done a lot of research and published. We have used as cultural relaxation as methods. If the person is Hindu, we use repetition of words like japa. The Buddhist, we can use pirit or chanting. Muslims, we can use the dhikr or zikir as it is sometimes pronounced. And Catholic Christians, we use the rosaries, the beads. Then some breathing exercises have been found to be very helpful to calm the breathing, to make it deep, diaphragmatic, slow, relaxing, particularly in the Buddhist Anapanasati or pranayamam in the Hindu system. Various forms of muscular relaxation, various asanas like Shanti asana, and some meditation techniques, and not to forget massage. Particularly people who have been tortured, massage can be very soothing and helpful in restoring their body image, which may have been lost due to the torture. Various forms of expressive therapy have been used in post-trauma, post-conflict situations, art, drama, narration, storytelling, trying to find meaning in what happened, expressing their emotions. In children, play has been very important. So these are used widely. So community approaches are effective in reaching large populations that are affected, particularly in a resource poor setting. Rather than individual approaches, we use a public health approach. There are large populations can be helped. So we create awareness through psychoeducation, pamphlets, through the media, training of community level workers, encourage rituals and ceremonies, particularly in relation to grieving, work with families, get groups functioning, and rehabilitation. So this and networking with other organizations that are involved, share the load, do mutual referrals, and use each other for different tasks. And of course prevention. Preventing war, preventing torture is very important. So awareness is done through pamphlets, dramas, lectures, and through medias. Coping strategies that are used traditionally, like rituals, festivals, can be very useful for communities to come back together, find meaning, share their what has happened to them, tell stories, and get on with life. Training of various levels of workers, community level workers, primary health care in basic skills and knowledge, and they can be a way of transferring knowledge to empower the community to look after the problems themselves. So there should be a referral pathway where people who have been affected more seriously can be referred for professional help, but most people in a post-trauma situation can be helped at the community level by appropriately trained personnel. So we have developed several manuals here which we use to train community level workers, and therefore there is a very useful tool to use in these situations. And we also emphasize networking with other organizations, inter-sector collaboration, so that there is some mutual sharing, and we can refer different problems to different people who are involved in different, they may have a different mandate. So if they find a person with psychological problems, they can refer to people working in the psychosocial field, while if there is an economic need or there is a legal issue, then you refer to that appropriate organization. And whole field of rehabilitation, trying to get the person back to where they were before, to re-establish their level of functioning, is time consuming but very important. So we try to develop programs that promote healing, recovery, and reintegration. Try to give importance to what the local population thinks is important, what are their needs, and what would they like to be addressed. We prioritize their needs, build up their leadership, build up their participation, so they become very active in their own recovery program. So in this way we can regenerate communities. Also, after a big disaster, it's very important to have symbolic like symbols, monuments, or cultural ceremonies where the emotions can be focused and people can come together and share what happened. So these are important also in the long term. management of trauma. Sometimes it's called traumascapes. So, I have tried to cover this whole field of trauma therapy in a very quick way. One is at the individual level where we use drugs and psychotherapy, at the family level trying to build up the family support system, understanding, and at the community level. And quite a lot of work can be done at the community level that you can help large populations with limited resources. Thank you.